Cardiogenic shock is a low perfusion state resulting in damage to tissues and to organs. The cause is a primary problem with the pumping ability of the heart. In short, a problem with the heart reduces the cardiac output. And as cardiac output is a product of both stroke volume and heart rate, it stands to reason that alterations of one or both of these factors is going to cause cardiogenic shock. Now, there are three main ways in which this can happen. The first and most prevalent is directly a decrease in stroke volume because something's prevented the efficient contraction of the heart muscle. Inefficient contraction directly impacts on stroke volume, and it's going to reduce this. The most prevalent cause of this is myocardial infarction, and during infarction, the occlusion of the coronary artery prevents the oxygen from reaching a section of the myocardial wall. This causes damage, and if not reversed, death to that area of the muscle. This prevents that section of the wall from contracting, and the affected ventricle cannot pump as powerfully, and stroke volume is going to fall. Should the occlusion affect a large enough area, the resultant fall in stroke volume will prevent the ventricle from forwarding sufficient blood and pressure to maintain tissue perfusion, and shock will follow. Other things that can decrease stroke volume include cardiac myopathies, such as hypertrophic myopathies, that make the ventricle stiff and less compliant. Although, more commonly, the ventricle becomes dilated and it loses its elasticity. In either case, the changes decouple the Frank-Starling mechanism and the increased preload can cause stroke volume to fall. The second way that stroke volume can fall is through incompetent valve action. For instance, should the mitral valve prolapse, the increased pressure during systole will force some of the blood through the valve and back up into the atria. This decreases the volume and the pressure available to open the aortic valve and results in less blood entering the systemic circulation. The third way in which cardiac output can fall is through alteration of heart rate. The simplest way to understand this is with a profound bradycardia, where the decreased number of times the heart will pump will cause the cardiac output to be insufficient. The other example lies in tachycardia. If these are fast enough, an accelerated heart rate decreases the ventricular filling time to the point the ventricle will contract before the sufficient blood volume contained within it. This again will decouple the Frank-Starling mechanism and the ventricle will not be stretched enough to guarantee adequate stroke volume. In many cases, more than one factor comes into play. However, the shock cycle will often start with a reduction in stroke volume, whether this be due to ischemia, myopathy, valvular incompetence, or heart rate. The reduction in stroke volume is going to lower blood flow to the organs, causing tissue hypoxia and acidosis to occur. These changes cause a sympathetic response, which under normal circumstances will cause widespread vasoconstriction, and this is going to raise the systemic vascular resistance. In the setting of cardiogenic shock, this can be counterproductive. An increase in systemic vascular resistance increases the work required by the heart to pump blood into the aorta. This can cause ischemia and/or further decoupling of this Frank-Starling mechanism. This promotes hypotension, which worsens the tissue hypoxia, and the shock goes into a downward spiral. We're now going to talk briefly about recognizing cardiogenic shock. And from a history point of view, we're looking for a clinical history of poor perfusion that's coupled with an acute myocardial infarction or decompensation of heart failure, and these things should raise the suspicion immediately for the presence of cardiogenic shock. Imaging and lab testing for cardiogenic shock are unavailable in the pre-hospital environment. Instead, paramedicine needs to rely on signs of hypoperfusion, and the subtle signs of this may include an altered form of cognition, including maybe anxiety and confusion. But the defining features of cardiogenic shock are low systolic blood pressure or a sustained fall in the mean arterial pressure where it remains at less than 60 millimeters of mercury. Depending on the exact pathophysiology and the extent of the insult, the indications for cardiogenic shock might show variance. An important distinction may be whether or not the cardiogenic shock is associated with congestion, or in other words, with pulmonary edema. Clinicians tend to label cardiogenic shock presentations that are associated with pulmonary edema as wet. If there is no congestion, then the shock is described as dry. The assumption is where the right ventricle has been affected, the shock is secondary to poor preloading of the left ventricle. In other words, the shock occurs because the damage to the right side of the heart causes low blood flow through the pulmonary circuit, and poor left ventricular preload is the problem. Under these circumstances, the blood pressure in the pulmonary circulation remains low, and the better performing left ventricle prevents a backup of blood in the pulmonary circuit. If all of this is true, acute cardiogenic pulmonary edema is very unlikely to form. Clinicians might refer to this as a dry presentation of cardiogenic shock, and that's because there's no evidence of pulmonary edema. Now, under these circumstances, using IV fluids to support the shock state is more likely to be beneficial. This is because the increased venous return associated with the fluids is likely to result in more blood reaching the left ventricle, and therefore the stroke volume is going to increase. Now, where the cause of the cardiogenic shock is directly linked to poor performance of the left ventricle, the opposite is likely to occur. Because the right ventricle is more likely to forward sufficient blood volume into the pulmonary circuit, and the left ventricle cannot clear it. So the pulmonary pressures rise and acute cardiogenic pulmonary edema will occur. In these circumstances, introducing IV fluid and increasing the preload of the left ventricle is likely to result in further decoupling of the Frank-Starling mechanism. This is going to cause an increase in congestion in the pulmonary circuit, and this can initiate or worsen fulminant cardiogenic pulmonary edema. The current CPG offers a workflow that helps with the thinking around this. Once anarrhythmia has been excluded as the cause, the CPG divides into a wet, that is, one that has pulmonary edema, or dry, with no pulmonary edema, approach. The primary differentiation between these streams is whether IV fluids is going to be used. If the presentation is wet, fluid is contraindicated. If dry, the CPG suggests that IV fluids would be useful, but we suggest paramedics investigate further for left ventricular changes before administering IV fluids. Now, should there be evidence of, say, an anterior lateral MI, fluid administration may be counterproductive and should be avoided in favour of the earlier use of vasopressors. I'm just going to conclude this section by emphasising the differentiation between cardiogenic shock with pulmonary edema and heart failure that's causing pulmonary edema. Unlike heart failure with acute cardiogenic pulmonary edema, cardiogenic shock will be associated with low output states. So the presence of pulmonary edema with a systolic blood pressure that's less than 90 millimeters of mercury, or a mean arterial pressure that remains at less than 60 millimeters of mercury, should lead a paramedic to favour a management strategy aimed at reversing the cardiogenic shock rather than lowering venous return to alleviate the symptoms of the edema. We're just going to move on to management. The broader management of cardiogenic shock is going to rely on 4 strategies, but the first and prime one is the management of the cause of the shock, such as being able to revascularize an MI or control anarrhythmia. The interventions that have the lowest mortality are those that reverse the underlying cause. So why paramedics need to initiate urgent management of cardiac shock when it's seen, the first goal, the primary objective, where this is possible, is to address the underlying cause. Thus, access to PCI or thrombolysis, or cardioversion and rate control would have preference over any other form of treatment. Once these have been initiated, but should shock still persist, the following strategies are the ones that we would then consider. So our second priority is management of blood pressure. The third is the provision of inotropy, or something that increases the force of cardiac contractions. And lastly, we would look to manage ACPO if it exists. In terms of the first goal, a fluid challenge may be helpful when perfusion is poor, but pulmonary edema is minimal. So this would be our warm and dry patient. However, in the case of left ventricular dysfunction, this strategy, using fluids, runs the risk of worsening pulmonary edema. The game plan when we're using fluids then is to go low and slow, such as 250 ml boluses with frequent checks on the respiratory rate, respiratory effort, oxygen saturations, and if there's any additional or worsening respiratory sounds. If pulmonary edema worsens, clinicians should immediately abandon any further fluid administration. So in poor perfusion states and where there is pulmonary edema, vasopressors may be helpful in the short term. In Aotearoa, New Zealand, paramedic procedures suggest using an alpha antagonist such as metaraminol to raise systemic vascular resistance and avoid direct beta stimulation of the heart so as not to worsen any ischemia. When this strategy fails to improve perfusion, inotropes are required. In the hospital setting, beta-1 selective inotropic drugs such as dobutamine are used. This is because the stimulation of the beta-1 adrenoceptors has a more substantial effect on cardiac contractions than it does on heart rate, and thus also limits ischemia. But this drug is not currently available in the emergency ambulance setting for Aotearoa, New Zealand, and the advisory group recommend the use of adrenaline for inotropy instead. So adrenaline is a broader acting sympathomimetic with strong alpha and beta effects. So we get the vasopressor effect that we would see with metaraminol anyway, and we see an increase in the strength of cardiac contractions. So in the setting of cardiogenic shock, it will act as a vasopressor and an inotrope. It's also going to stimulate the beta-2 adrenoreceptors, and so it's likely to promote an unwanted tachycardia. But to mitigate this, or to some extent to mitigate it, adrenaline is administered in a very diluted form. You'll find the commentary in the extended CPGs is very helpful in terms of describing and managing this. So this brings us to the end of this tour through cardiogenic shock. And just by way of recap, I just wanted to iterate pump failure is the main problem. So it's a direct cause by the heart that has either reduced stroke volume through the likes of an acute myocardial infarction, myopathy, the structural problems that we discussed like valve failure, or whether it was directly related to an arrhythmia where the heart rate wasn't fast enough or the rate itself was going to reduce the stroke volume. We've talked briefly about the classification of heart failure, the vital signs that we need to confirm it, and how we might view perfusion and congestion as to how serious the presentation was. And finally, we looked at the management priorities and have stressed that managing the underlying cause is the most important goal, and that we should get treatment underway, or at least make arrangements for things like revascularization before we move on to the other treatment priorities. From there, we can look at three main branches to treatment. One is the management of blood pressure, and we discussed whether fluids may or may not be helpful in that setting, and the cautions that we would undertake if we were to use fluid therapy. We talked about metaraminol for the control of blood pressure, and then we discussed inotropy and the use of adrenaline in particular, and how that may also be a two-edged sword in terms of it producing tachycardias and ischemia. The one thing we didn't discuss in this was the management of ACPO. This has been covered in other sessions, and I'm sure you can review those to look at the main structures that we would use in terms of addressing where this is present. But it should go without me having to say it, that obviously the use of nitrates in this sort of situation would be spectacularly dangerous. CPAP or PEEP may offer some advantages. However, these can also have a negative effect, and ongoing monitoring of the patient is essential. I hope this has been useful. If you've got any inquiries around this, please feel free to get hold of me. Ka kite.